Today I will reflect on my experience of performing ultrasound guided peripheral intravenous cannulation on a difficult intravenous access patient in the day therapy unit in my workplace. I'll follow the Gibbs reflective cycle, which consists of description, feelings, evaluation, analysis, conclusion, and an action plan. So during my shift in the day unit, I was tasked to insert an ultrasound guided cannula for a patient with a history of difficult intravenous access. The patient was very cooperative and expressed confidence in my use of the ultrasound technology, which was great. I prepared my critical aseptic field, connected my tablet to the Lumify probe, and conducted a pre-scan to locate a suitable vein. I identified a vein approximately 0.8 of a centimetre deep that I believed was appropriate for access, albeit quite shallow. However, I encountered challenges during the procedure. I struggled to position my trolley, firstly, and ultrasound screen in a way that aligned with my line of sight. My placement interfered with my probe use, creating a physical barrier. Additionally, despite altering the gain, I had difficulty tracking my needle tip during the insertion, which had not been obviously an issue when we were practicing on the Blue Phantoms. I later realized that I had not adjusted the machine's depth settings appropriately to reflect the superficial nature of the vein. I suspect that my probe may have shifted slightly as well during the insertion procedure, which misaligned the needle's trajectory. Ultimately, I couldn't cannulate the patient this day. During the procedure, I felt confident initially, given my recent training with Evan. However, as the challenges arose, I began to feel frustrated and slightly anxious about the potential discomfort I might be causing the patient, especially as time went on. Initially, I believed that the technology itself was not providing a clear enough image because I just had the Lumify probe, and I was questioning whether it was adequate for the task at hand. It is quite old as well, but doing some investigation, the probe was fine. As the procedure continued and I reflected on my actions afterwards, I recognized that the issue was more related to my technique rather than the technology itself. My ability to properly adjust the depth setting, my inability to properly adjust the depth settings and maintain consistent probe positioning, I think played a significant role in my failure and the difficulties that I faced. I felt a sense of disappointment and inadequacy when I realized I couldn't complete the cannulation successfully, especially after being cannulating traditionally for so long. But despite this, the patient remained understanding and supportive, which helped me manage my stress. On a positive side, I successfully identified a suitable vein during my pre-scan and maintained a critically sterile field throughout the procedure. My patient communication was clear and I upheld a professional patient-centered approach. The negative aspects included my difficulty in positioning the trolley, my inability to accurately track the needle tip, which ultimately is the key to success, and my oversight regarding the depth adjustment. Additionally, I underestimated the variability in vein size as the vessel tracked proximally towards the patient. I had not picked up on the pre-scan that the vein seemed to cone in as I moved the probe proximally, which I thought was a bit weird, making it hard to track both the needle tip and the vein as I progressed the needle. This experience highlighted the gap between simulated practice and real-life application. On the Blue Phantom, veins are static and consistent, whereas real patients present dynamic, less predictable anatomy. The challenge of positioning equipment effectively within a busy clinical environment also appeared to be a factor that influenced my success. Not adjusting the depth settings contributed significantly to the issue. Had I set the machine for a more superficial vein, I think the needle tip might have tracked more visibly. Additionally, the misalignment between my probe and needle emphasized the importance of probe stabilization and constant awareness of its positioning. It also highlighted how important the pre-scan is, not just in identifying surrounding vasculature, but also ensuring that the vein you have chosen is actually suitable for at least, in this case, 5 centimeters, because I was using a 48 millimeter long needle, so that you can actually get the cannula in successfully. Reflecting on the experience, I could have spent more time refining my equipment positioning before beginning the procedure. Practicing different trolley arrangements in advance could have preempted the interference issue. I should have double-checked all the ultrasound settings, particularly the depth, as part of my pre-scan routine. I think I need to practice keeping my hands steadier and fanning the probe more than moving it. I feel like I anchor the probe well with my fingers on the patient's arm, but perhaps I need to change my whole body position so my arm isn't strained. Maybe sit down and rest my arm on the patient chair rather than standing up. And most importantly, I need to make sure my pre-scan is a lot more thorough when it comes to choosing a suitable vein. I've actually done quite a few successful ultrasound guided cannulations since this event, including on this patient, which has really helped build my confidence. I want to create a pre-procedure checklist acronym in my head that I can remember to help me remember the key steps, like adjusting the ultrasound settings. But I feel that the more I practice, the more I'm kind of subconsciously getting my own sort of routine anyway. I know when I was like learning traditional cannulation, I used to count in my head when I was getting all the stuff out to help remember, making sure I didn't forget anything. So, and I found that really helpful. Using ultrasound technology does seem to take a lot of time to set up, especially when you're quite busy in the unit. It'd be good if I could purchase an attachment that popped the Lumify tablet above the back of the trolley and something to hold the probe as well, keep it nice and safe. This would really, I think, dramatically reduce the amount of time it takes to set up, and also help with working in that linear fashion, because the screen would be behind the trolley, as long as it didn't interfere, obviously, with my critically aseptic field. I've definitely been conducting more thorough pre-scans to ensure I pick up on vessel changes, especially with those really difficult patients. But I really want to seek further mentorship from my colleagues, which is hard because they're not always in the unit, the colleagues that are ultrasound competent. But just sit down and have chat, like debriefs with them, I think, about certain cases to help pull little bits of skill from them and really refine my practice. Thank you, Evan, for the chance to complete this course. It's been extremely beneficial for both myself and my colleagues, and more importantly, priceless for the patients with difficult access. Thank you.